Okay, I invite my third speaker, Dr. Vinod Baladhir. Welcome, Dr. Dheer. I'm really eagerly waiting to hear this most important topic. I was surprised what it is in this topic. Last, what is new? Is it the time when it was introduced and where it was introduced, or not so new to a teaching hospital, but maybe new to a district hospital, as we have discussion in the airway lecture, between the chairperson and the speaker. So what is really new? I'm eagerly waiting for you to listen. So I'm sure many of our answers will be, our questions will be answered.
Today I'll be talking about local anesthetic systemic toxicity. As you all know, this is a life-threatening adverse event. Its incidence is around 0.03%. Patterns of presentation have evolved over the years due to increased use of ultrasound-guided blocks, resulting in delayed onset. Also, there is greater incidence secondary to high-volume facial plane blocks, continuous catheter techniques, and tumescent anesthesia. Increased incidence has also been reported with local anesthesia given by non-anesthetists. Mechanism of toxicity. Local anesthetics binds to intracellular sodium channel, inhibiting neuronal ion transfer and depolarization, preventing neuronal transmission. They also binds and blocks potassium channel, calcium channels, and sodium potassium ATPase channel, and interfere with intracellular and transmembrane cell signaling. Also impairs mitochondrial metabolism, ATP production, inhibit ryanodine receptor at sarcoplasmic reticulum, reduces calcium sensitivity of myofilaments. Central nervous system toxicity. Local anesthetics compromises cortical inhibitory pathways by blocking sodium channels, resulting in excitatory clinical features of sensory and visual changes, muscular activation, subsequent seizure activity. Later on, excitatory pathways also gets affected, resulting in depressive phase of neurological toxicity with LOC, coma, and respiratory arrest. Cardiovascular toxicity. Sodium channel blockade, especially at bundle of His, results in prolonged PR, QRS, and ST intervals, and potassium channel blockade results in prolonged QT interval. Sodium-calcium exchange pump blockade interfere with ATP production, causing impaired myocardial contractility, decreased cardiac output, and hypotension. pH-related suppressive effect on baroreceptors and systemic vascular tone results further fall in blood pressure. Now coming to the various types of toxicity seen with local anesthetic agents. Central nervous system toxicity. It is seen when the plasma concentration of local anesthetic agent is more than 6 microgram per ml. This is the most common feature of last, accounting for 68 to 77% of the cases. This is a two-stage process, excitatory phase and depressive phase. In excitatory phase, there is perioral tingling, tinnitus, slurred speech, lightheadedness, confusion, agitation, generalized convulsions. Followed by depressive phase, in which there is LOC, coma, and respiratory depression. Cardiovascular system toxicity. This is seen when the plasma concentration of local anesthetic agent is more than 10 microgram per ml. 1/5 of the last present with isolated CVS symptoms, whereas 1/3 of the last begin with CNS features and progress to involve CVS signs. It has 3 phases. Initial phase having hypertension and tachycardia. In intermediate phase, there is myocardial depression and hypotension, whereas in terminal phase, there is peripheral vasodilatation, severe hypotension, arrhythmias such as sinus bradycardia, conduction blocks, ventricular tachyarrhythmias, and asystole. Anaphylaxis is more likely seen with ester than amide groups. Also seen with preservative like methyl paraben or metabisulfites. Next is methemoglobinemia, which occurs with prilocaine due to its metabolite O-tolvadine. Local reactions. Allergic reaction to para-aminobenzoic acid, which is an ester metabolite. Management of LAS. Prerequisites. Before giving local anesthesia, must ensure availability of oxygen, intravenous access, monitoring for at least 30 minutes after giving local anesthesia, availability of resuscitation drugs and equipment, availability of LAS kit. The LAS kit contains printed checklist for managing LAS, 500 ml bag of 20% lipid emulsion, IV tubing, 50 ml syringes, and large bore needles. Diagnosis. Consider last whenever signs and symptoms of CNS or CVS instability occur in any patient who received local anesthesia. For diagnosis, we need to recognize symptoms and signs which are suggestive of systemic toxicity. These have been discussed previously. Important here is to note that CNS signs may not be visible in anesthetized patient. Initial management. First of all, stop injecting local anesthetic agent. Call for help and the last kit. Maintain airway, ventilate with 100% oxygen, aiming pneumocapnia. Confirm or establish an IV access. Seizures should be controlled with benzodiazepines. Further, propofol and thiopentone can be used in small doses if there is no cardiovascular instability. Management of cardiotoxicity. In circulatory arrest, follow ACLS algorithms with the modifications listed below. Oxygenation, ventilation and cardiac compressions are paramount. Start intravenous lipid emulsion if not already started. Reduce adrenaline dose to less than 1 microgram per kg where possible. Administration should be preceded by initiation of lipid emulsion therapy. Do not use vasopressin. Amiodarone may be used but avoid beta blockers, calcium channel blockers and sodium channel blockers. Consider cardiopulmonary bypass if the above measures are not effective. 20% intravenous lipid emulsion therapy. Bolus is given at the rate of 1.5 ml per kg over 2 to 3 minutes. Continuous infusion is given at the rate of 0.25 ml per kg per hour over 10 minutes. In persistent cardiovascular instability, repeat the same bolus after 5 minutes. Double the infusion rate to 0.5 ml per kg per hour. Further boluses can be given a maximum of 3 including the initial bolus. Maximum 30-minute cumulative dose is 10 ml per kg. Mechanism of action of intravenous lipid emulsion. Precise mechanism of action remains unclear. Suggested mechanisms include lipid sink hypothesis. ILE forms an expanded lipid compartment within the intravascular space, displacing local anesthetic from its receptor sites. Number 2 is enhanced fatty acid metabolism. ILE provide a source of fatty acid to rescue metabolism. Transfer the patient to HDU or ICU for appropriate monitoring. Patient who develop neurological symptoms should be observed at least for 2 hours after recovery, and the patient who develop cardiac symptoms should be observed for at least 6 hours after recovery. Regular clinical review to exclude pancreatitis. Report cases and use of intravenous lipid emulsion therapy to the following sites. Risk factor and preventive measures. No single intervention eliminates the risk and therefore prevention is a multifactorial process. Local anesthetic and method. Choose least cardiotoxic local anesthetic, for example, lignocaine, or method with the lowest anesthetic dose required, for example, spinal, wherever it is possible. Following table shows the maximum dose of various commonly used local anesthetic agents. For example, maximum dose of lignocaine without adrenaline is 3 to 4 mg per kg body weight, and with adrenaline it is 7 mg per kg body weight, and that of bupivacaine and levobupivacaine is with 2 mg per kg body weight with and without epinephrine, and that of ropivacaine is 3 mg per kg body weight with and without epinephrine. Block factors. Site of injection. Consider adrenaline to limit local anesthetic bioavailability where risk of systemic absorption is high. Block conduct. Ultrasound guidance significantly reduces the risk. Incremental injections. Aspiration before injection. Consider using adrenaline as a marker of intravascular injection. Block in awake patient theoretically allows earlier detection. Avoid over-sedating the patient while placing a block. Patient factors. Reduced doses are to be used in infants, elderly and in pregnant females. Consider reducing the dose in hepatic disease, CKD and cardiac diseases. Further careful consideration must be done in patients with malnutrition, hyperproteinemia, diabetes and metabolic disorders such as carnitine deficiency. Non-technical factors.
knowledge and education of all staff where local anesthetic is administered, at-risk patient groups, signs and symptoms of LAS to facilitate prompt recognition, treatment guidelines, considers stocking a last box, communication. Be vigilant where other providers may also administer local anesthetic in the perioperative period to avoid excessive total dose. Consider including a local anesthetic dosing in anesthetic records. Thank you everyone for your patient listening.
It was a really very elaborate one. Sorry, I mistook the topic. It was local anesthetic systemic toxicity. And there was one question, why to avoid vasopressin?
We should avoid vasopressin because it causes intense vasoconstriction resulting in metabolic acidosis, which in turn further increase the local anesthetic toxicity.
Okay. I hope Saurabh Sagar, who had asked questions, got it cleared. Okay. I thank all the speakers and the chairpersons and RML Hospital. Thank you so much for inviting me. It was a pleasure to be with you all.
Thank you, ma'am.
Thank you so much, ma'am. Thank you so much for your gracious presence, ma'am. And thank you, Vinod Bala, ma'am, for such an enlightening presentation.